Good afternoon, everybody. I promise 10 minutes. I know I'm keeping you away from your lunch, and after a wonderful morning, Dr. Chakma, hats off to you for your one brilliant research, and Dr. Yajnik and Dr. Kurpad. I mean, I feel blessed to be living in times of nutrition, and actually, Dr. Kurpad's talk took me to what are we giving our Gen Zs and our Gen Alphas, and now the Gen Betas. So we need to buckle up here. So it's going to be a quick talk from research. I'm going to be jumping directly to clinical practice. Probably, I hope I gave you some quick take-home messages as what levels are we going to be looking at. My topic is markers of metabolic health, 8 specific criteria. So a quick run through with metabolic syndrome. It's already been done for the last 3 hours. Traditional markers, pediatric population markers, and in novel markers. So we know about metabolic syndrome being we've seen enough about that talk since morning about an escalating worldwide problem because of over energy, over nutrition, and that's what we meant by, giving our next generations. The implications being a 5-fold increase in the risk of diabetes and 2-fold increase in risk of cardiovascular disease over the next 5 to 10 years. So the prevalence varies worldwide as per age, sex, race, geographical location, nutritional status, and all that things. But the bottom line is probably the IDF estimates that 1/4 of the world's adult population would have metabolic syndrome. So we know about the 5 key parameters of metabolic syndrome, which is obesity, which is central obesity, not generalized obesity, hyperglycemia, hypertension, dyslipidemia, and lipid peroxidation. So we know these are the criteria. Actually, we have many bodies which have come up with criteria for metabolic syndrome, but technically what we follow is the IDF. And now the latest, the WHO, which has come up. So IDF generally would mention central obesity. Central obesity means truncal obesity. How do we measure central obesity? By waist circumference. How do we measure waist circumference? Where do we measure waist circumference? We do it the right way. It's not at the umbilicus. It's a midpoint between the lowest, the 12th rib and the highest point of the iliac crest. The midpoint between those 2 parameters is your waist circumference. And along with that, any 2 of these 4 parameters, which is a high triglyceride, a low HDL, a high blood pressure, and a high fasting glucose. LDL doesn't feature here. You realize that, right? So as we talked about, there are multiple bodies which have given up, but the 2 popular ones are the IDF criteria and the modified WHO criteria. Now, the WHO criteria basically places more emphasis on the fasting blood glucose. That has to be the main criteria, and that's come up a little later than the IDF criteria. And along with altered glucose levels, any 2 of the 4 parameters, which is say waist-hip ratio or blood pressure or triglycerides or a low HDL. So essentially, these are 5 components all across, but how we give more importance to one is what the technically the guidelines differ. So I'll skip this. We all know basically we've learned about it's not just overnutrition, it's a lot of genetic, epigenetic factors which come into play, a lot of environmental pollutants, be it stress, be plastic pollutants, be EDCs, the endocrine disrupting chemicals, too many things in action, stress, lack of sleep, too many things being in action in current times, which lead to insulin resistance, visceral adiposity, HPA dysregulation, which leads to chronic hyperglucocorticoid excess. So we have people coming up telling us, my cortisol levels will be high. And is that a marker for metabolic syndrome? So this is not to be tested for cortisol, should not be tested unless it is clinically indicated. But yes, high HPA dysregulation would lead to low growth hormone secretion, high cortisol levels, and dysfunctions in the renin-angiotensin system. And obviously the atherogenic dyslipidemia. So what are the markers? Clinically, we all know this. The clinical markers of metabolic syndrome is acanthosis. And acanthosis typically we would see in all flexural areas, the commonest being the nape of the neck, the underarms, but basically every single fold area. It could be under the breast. It could be as simple as on the knuckles. Just look at the hands of the patient. If you find darkened knuckles, that's probably acanthosis there. And in fact, we actually grade acanthosis 0, 1, 2, 3. But yes, acanthosis and skin tags are clinical markers, but we don't see them in all patients who might have the metabolic syndrome. So now coming to each criteria of metabolic syndrome, the first criteria we talked about, obesity, or central obesity. So when we look at obesity, we look at the Indian guidelines, and Dr. Yajnik and Yudkin, the YY paradox is has actually been the benchmark for defining a lot of studies in India, which now put Indians, Asians to be obese or to be overweight at more than 23 BMI. The international criteria is 25 BMI and above is overweight. For Indians and Asians, it is more than 23. So normal BMI for Indians would be between 18 to 22.9, and thereafter it is more than 23 is overweight, more than 25 becomes obesity. Now, waist circumference, anything more than 90 centimeters in men and more than 80 centimeters in women is at risk for metabolic syndrome. Now, this same doesn't apply to children, as Dr. Kurpad said. So, and for children, it's a totally different ballgame. We always look at percentile charts. We look at the Z scores, and today we have the BMI percentile charts. These are published by the IIP, and they are easily available online. So we don't look at just a BMI of 12 or 15 or 18 or 20. We need to plot them on BMI charts. It's available for boys as well as girls, and it's used for more than 5 years of age children. Less than 5 years, there are WHO charts, but these IIP charts are for kids more than 5 years of age. So they have the percentile lines which talk for more than 23, which are equivalent to 23 for a number for adults being as overweight, and more than 27 for adults being as obese. So that was BMI. We don't have any waist circumference cutoffs for children. Coming to lipids. Now, again, these are guidelines given by the Cardiology Society of India. And what are the optimum lipid levels? I put LDL there, but what is primarily important in metabolic syndrome is all triglycerides to be less than 150 as a cutoff, and HDL, which should be less than, should be more. So it should be more than 40 in men and more than 50 in women, across all criteria for risk for the patient. So right now, I'm going to be swinging between adult and pediatric. So this is for adults. So adults, more than 40 for men and more than 50 women HDL across all risk factors in terms of their cardiovascular risk. If somebody who's not had an MI to somebody who's had MI, stents and a low ejection fraction, you'll need to get more stringent there. Then comes LDL cholesterol, which is very strongly implicated not in metabolic syndrome, but more with cardiovascular disease. So the higher the risk of the patient, the lower the LDL should be. So the cardiologists talk of keeping the LDL as low as even 30. So we have new drugs which are coming up there. So that would be the high risk population. So for the low to moderate risk population, it should be less than 100. The other factor is the lipoprotein, the little lipoprotein, which should be ideally less than 50 across all risk categories. Then coming to, this was again update by the Lipid Association of India, looked at LDL and the non-HDL cholesterol and the ApoB. So lipoprotein A, ApoB are not easily available for most of, if you go down to the Tier 2 and the Tier 3 cities, it's not easily available. Even in Mumbai, only a few select labs would do it properly. So we really don't put more emphasis on that, lipoprotein A or ApoB or ApoB, because of ease of lack of availability. But if you would have them, then these would be the criteria. Now, among them, non-HDL is a little easier to calculate. So non-HDL cholesterol means total cholesterol minus the HDL. So that everything else, that would include LDL and the VLDL. All that should be ideally less than 130 for low risk patients. But if you have somebody who is a severe or a high risk patient, you would go to even probably under 100 or even under 80. So these are clinical criteria cutoffs which are given. Coming to children and adolescents. So there are specific criteria for children and adolescents. And again, this is published in journals, the Journal of Clinical Medicine. So what is acceptable for children? This is for under 18 years of age. Total cholesterol needs to be less than 170. That is supposed to be good. LDL needs to be less than 110. So it's interesting to keep that, you can keep it up to about 100, 110 is okay. HDL needs to be more than 45. Non-HDL less than 120. So these are all the acceptable ranges. Now, when we talk about this is a lipid profile, but when we're talking about metabolic syndrome in children, as Sir said, it's very difficult. There's no definition for metabolic syndrome in children. What would then generally would consider two parameters would be obesity and triglycerides. Low HDL does not give so much is not given so much importance or does not have so much implications in children to define as metabolic syndrome. Dysglycemia, fasting blood sugar could be considered as one. So when we look at among the three, it's obesity and triglycerides, which would be as a lab marker, which we would looking at for screening for metabolic syndrome in children. And the cutoff for triglycerides, if the child is younger than 9 years, needs to be less than 75. That's ideal. And if it's somebody older than 9 years, a triglyceride less than 90 is normal. So 90 to 130 is somewhere we would start worrying, and anything more than 130 in children, of a triglyceride of more than 130 in children would definitely be red flags. So after lipids, we come to blood pressure. Now, blood pressure guidelines, again, every 3 to 4 years, guidelines keep revising targets. So in the last 30 years, I think NCAP1, the JNCs 5, 6, 7, 8 have come up. NICE guidelines, KDIGO guidelines, every guideline keeps changing. So this is the latest NICE guidelines, which say that for adults under 80 years of age, the blood pressure could be kept less than 140/90. That's stage 1, where we probably look at lifestyle modification only, but more than 140/90 needs medications. Home BP targets, they say keep it less than 135/85. But any degree of proteinuria or CKD, the targets for blood pressure should be lower. So 125/75 in our CKD patients or patients with albuminuria. The KDIGO guidelines, which is the kidney guidelines basically, they look at more stringent. They would keep it blood pressure less than 120/70 in those patients. So, it's basically the targets, the lower the better, but for adults, as of the latest guidelines, up to 140/90 is considered to be okay. Again, coming to the pediatric BP population, then the pediatric population, what's the blood pressure targets we would keep at? There's no defined target number. So again, we have BP percentile charts. So pediatrics, everything has to be charted on percentiles, and any blood pressure more than 90th percentile, less than 90th percentile is considered normal. 90th to 95th would be stage 1 hypertension, elevated blood pressure, which calls for probably close monitoring, and anything more than 95th percentile would be categorized as stage 1, and more than that, stage 2 hypertension. So these are guidelines which are easily available on the net. So when we have dealing with a child with overweight, or looking at metabolic syndrome and you look at their blood pressure, we need to refer to these charts. So putting in a nutshell, what are the pediatric cutoffs for metabolic complications? This would be it. It's by the Indian Academy of Pediatrics. The guidelines come up in 2022. Blood glucose fasting less than 100. So blood glucose remains essentially the same for children or adults. So fasting less than 100, post glucose less than 140, and the glyco-HP less than 5.7. Total cholesterol less than 170 is ideal. LDL should be less than 90, triglycerides less than 90, HDL should be more than 45, and ALT. This is an interesting thing which is now getting added. I think it's time for metabolic syndrome criteria to be revised, because we're seeing too many conditions associated. So these are the preliminary, these are the main markers which have been well studied. But when we now look at the current population, fatty liver, NAFLD, the terminologies change from fatty liver to NASH to NAFLD, and now we're talking about MASLD, which is metabolically active steatotic liver disease. And that is a real risk running in the population. So apart from glucose, so let's talk about glucose first. We talked about criteria, but when we talk about keeping our diabetics under control, we would aim for an HbA1c less than 7. But there are again caveats to this. If it's somebody young who's got a long life expectancy, no comorbidities, we could aim for even less than 6.5. But at the other end, when we have somebody with CKD or heart failures or with limited life expectancy, even an A1c of up to 8 is okay. So we shouldn't be pushing our elderly 70 plus patients to less than 6 in any case. Now, when we talk about MASLD or NAFLD previously, we look at ALT elevations, that's SGPT elevations. Then there's something called as a FIB score, which we are now starting to use in commonly. It's a calculated score which looks at the age, the platelets, the SGOT and the SGPT. It's an online calculator. There are cutoffs for that. Anything less than 1.5 is considered okay. More than that becomes worrisome for fatty liver, and FibroScan, of course. Uric acid is another, not very much studied marker, but it does come up as a part of metabolic syndrome. So one of the consequences or fallouts of metabolic syndrome, apart from diabetes, blood pressure, and dyslipidemia, would be fatty liver, hyperuricemia, and PCOS. The last would be body fat composition. So, we're now looking at not just the BMI, we're looking at body fat mass, right? And there are impedance analyzers are available, though DEXA stands the gold standard for being the most accurate for measuring body fat mass. This BI is something which is easily available in the clinics, and we can do that. And we look at body fat percentages. And these body fat percentages, though these are old data, but we have data for men and women at each age range. Less than 20, 20 to 35, 35 to 55, 50, more than 55, more than 75. So as we grow older, sarcopenia increases, body fat percentage increases. So what is it? So technically we would say for a young male less than 45 years, 35 years of age, a body fat percentage should be between 9 and 15%. Whereas in the same age group, a woman could have a body fat percentage about 20%. So there are criteria available, but I think everything is coming up for revision. So we need to wait for more data to look at. Then coming to novel markers, which I'll quickly run through because these are what you see in labs. Labs give you interleukins, labs give you TNF, they give you CRP, they give you ferritin. If you go through so I'm not taking labs names, but every lab when you ask for a package, all these are included: hsCRP, interleukins, TNFs, and ferritin. So the few ones which are being studied, but again, as I said, we don't have guidelines on any of these as markers. One would be free fatty acids, which are inflammatory. So they talked about, the previous speakers talked about adipose tissue being the most, it's the largest endocrine gland in the body, by the way. It's not the pituitary or the thyroid or anything. The adipose tissue is the largest endocrine gland because it's a very active gland which secretes a lot of inflammatory cytokines. Most of them would be inflammatory. There are only a couple of them which are anti-inflammatory. So TNF alpha is again an inflammatory cytokine, reduces insulin sensitivity and as well as inhibits the insulin receptor. CRP is again used to predict CV mortality, CV morbidity in patients of metabolic syndrome. But mind you, again, if you see the cutoffs as 1.5 as a limit, anything could be positive. So, there are studies which are trying to look at what range we would call it mild, moderate or severe, but we don't have the final word as yet. Interleukin 6 is another promising a marker for metabolic syndrome. Plasminogen activator inhibitor. This again is an inflammatory marker, but more so as a procoagulant or a prothrombotic marker, and these are increased in patients of metabolic syndrome. Adiponectin is one of the protective adipocytokines which is secreted by the adipose tissue. There are only two which I have come across. One was adiponectin. Anybody else? Someone as a second guess, which is one of the protective adipocytokines. Okay, we'll come to it at the end of the talk. Leptin, very commonly used marker. We all do, when somebody who has an obese child or obese adult, people tend to ask for leptin levels, but mind you, there are no cutoffs. Leptin levels are increased in patients with obesity. So whether it's a cause or a marker, the bottom line today, as per evidence, we consider these to be markers of metabolic syndrome. Again, there's no cutoff there, and leptin levels are not easily available. So this was some study which looked at beyond the traditional markers of HDL, triglycerides, and the glucose levels. They looked at TNF and the CRP, and they say that high serum concentrations of pro-inflammatory and atherogenic indices, including CRP and TNF, could be potential markers for metabolic syndrome. Now, this was what I was talking about. I know it's a very busy slide, but there's only one other hormone. Adiponectin is not mentioned here. It's omentin. So omentin, if you see that, that's the only one which is reduced in patients with metabolic syndrome. So adiponectin is reduced in patients with metabolic syndrome. Omentin is reduced in patients with metabolic syndrome, but they have resistin, you have visfatin, you have the interleukins and everything else. And there's so many complicated words there, but these are all just being studied. So we'll probably have to wait at least for a decade more to have more results on cutoffs and guidelines. So then insulin resistance, again a very popular topic, and we endocrinologists love to bash this up. But insulin resistance is one of the key markers. But tell me, how many of you use insulin levels to diagnose metabolic syndrome? Honest answers. Yes. And what cutoff levels would you use to diagnose metabolic syndrome? 10? Okay. With the eyes. Okay. Anybody else, ma'am? More than 25? And I think I saw 5 hands up there. Yes, ma'am? 10. So in this gathering of 150 people, we still don't have a clear-cut guidance about what is the cutoff to use. Correct? So we don't have a cutoff to diagnose insulin resistance based on a simple fasting insulin level. So please don't do an insulin fasting. Please don't do an insulin PP. It doesn't really make any sense. Insulin levels are basically used in academic purposes to figure out, if we want to correlate things, we are looking at that part of it. But there are a lot of variabilities in the assays. And if you have somebody who's looking overweight to you, who has acanthosis, but an insulin level of 12, would you call that, but an insulin level of 9, would you call that insulin normal, sensitive? No. The cutoff, the lab range for insulin is 5 to 25, by the way. So there's no cutoff value for beyond which we will say it's insulin resistant or insulin sensitive. So then we come about looking at measures of other insulin resistance which include logarithmic calculation, would be HOMA, IR, and the quickie indices. These are a little better as compared to a basic insulin level, but again, because when the basic insulin per se is questionable, even HOMA, IR, what are the cutoffs you use? Some labs use 2, some labs use 2.5, some labs use 3. So again, there are no standardized cutoffs. And this I'm talking about in the adult population. Pediatrics doesn't even come up here, okay? The other popular marker which is now coming up is TYG index, which is triglyceride glucose index. Now this doesn't use insulin, and this is now being studied. Actually, it's been studied for the last 30 years, but there are a lot of associations of this TYG index. It's a logarithmic calculation which looks at triglyceride and the glucose. And it is a good surrogate for insulin resistance. It can be used as a good surrogate for serum insulin. And there are a lot of studies, not only for obesity, but also for diabetics and fatty liver, and even PCOS, which are looking at TYG index as markers of insulin resistance. So bottom line, to sum it up, obesity, metabolic syndrome is a complex interplay of genetic, lifestyle, and sedentary diet and lifestyle habits. There are many markers which are available. The studied markers we've enumerated, which are basically pertain to triglycerides and HDL cholesterol, and if you have available the small dense LDL or the ApoB, which can be used. There are a lot of inflammatory cytokines and which are used as markers. Ferritin is again it's a topic of debate whether it's a cause or a marker of insulin resistance becomes an issue there. Resistant bisfat, or most of the inflammatory cytokines are increased in patients with metabolic syndrome, and only 2, which is the protective cytokines, which is adiponectin and omentin, these levels are reduced in patients with metabolic syndrome. So these are actually protective cytokines. And oxidative stress, there's a whole lot of compounds waiting to be researched further. So thank you for your patient hearing. I hope